Welcome to the deep dive. Our source material today is pretty ambitious. We're spanning foundational anatomy and some key clinical correlations across, well, three massive body regions.
We really are. We're looking at the thoracic wall's protective shell, then diving into the complex layers of the abdominal cavity and the peritoneum, and finishing up with the crucial support system of the pelvic floor.
Right. That's a huge amount of clinical real estate, like you said, from the ribs all the way down to the anal canal.
Yeah, and our mission today is really to pull out the absolute must-know facts, the anatomical nuggets, that directly translate into better diagnosis or safer surgical practice for you, the learner.
We're definitely not here to just read the textbook. We
Yes.
want to interpret the clinical significance of these structures.
Exactly.
So we'll start by laying out the framework of the thorax, looking at the bony protection and some common injuries. Then we'll transition down to sort of navigate the dynamic setup of the abdominal wall and the fluid dynamics within those peritoneal sacs.
Right, how things move around in there.
And we'll wrap up our deep dive in the pelvis, focusing on those dynamic support structures and the neurovasculature that, well, often get compromised later in life. Okay, let's start with part one, the bony framework of the thoracic wall, specifically ribs, cartilages, and those intercostal spaces.
Sounds good.
When we think about ribs, most people just picture, 12 similar curved bones. But the authors spend some time detailing specific variations, especially in the lower ribs. What makes the 10th through 12th ribs stand out anatomically? And why should we care clinically?
Well, it really boils down to how they connect their articulation and how much they can move. A typical rib, maybe like the 5th rib, connects to two vertebral bodies.
Okay.
But the 10th, 11th, and 12th ribs, much like the very first rib actually, have a simpler joint. They only have a single facet on their heads.
So just one connection point on the vertebra.
Exactly, meaning they articulate with just one vertebra. And clinically, the 11th and 12th are the most distinctive, they're short, and they completely lack both a neck and a tubercle.
Ah, the tubercle. That's the bit that usually connects to the transverse process, right?
Precisely. So without that tubercle connection, they have much more freedom.
That makes sense. So that lack of articulation gives them significant mobility. What about the front connections, the costal cartilages? They're obviously key for the chest cage's elasticity. How do they attach to the sternum?
The pattern there is very precise, and it really dictates the stability of the whole rib cage. The first 7 costal cartilages attach directly and independently to the sternum. Nice, firm anchorage for each.
Okay, ribs 1 through 7, direct connection.
Right. But then ribs 8, 9, and 10, they articulate only indirectly. They actually connect to the cartilage immediately superior to them.
Ah, so they piggyback onto the one above.
Kind of, yeah. They form that continuous arched costal margin that you can feel.
Right.
And finally, ribs 11 and 12, those are the floating ribs. Their cartilages are just these small free caps sort of embedded in the abdominal wall muscles. They don't attach to anything else centrally.
So structurally, injuring, say, the 4th rib is mechanically very different from injuring the 9th, which is part of that shared chain.
Absolutely. The forces are distributed differently.
Okay, now let's look at the spaces between the ribs, the intercostal spaces. These are vital zones for nerves and vessels. How are they named?
The naming convention is critical, especially for localization during procedures like putting in a chest tube. A space is always named according to the rib that forms its superior border.
Superior border. Okay.
So the 7th intercostal space lies between rib 7 and rib 8. And following that pattern, we have 11 such spaces and naturally 11 corresponding intercostal nerves.
That covers 11 spaces. But that leaves us below the 12th rib. What happens to the segmental nerve supply as we move down towards the abdomen?
Good question. Below the 12th rib, we don't really have a true intercostal space anymore. That area is called the subcostal space.
Subcostal.
Therefore, the anterior ramus of that spinal nerve, T12, gets a unique name, the subcostal nerve. And this nerve is an important boundary marker. It's the highest segmental supply to the deep layers of the anterior abdominal wall, sort of bridging the thoracic cage mechanic to the dynamic structures below.
All right, move to the midline now. The sternum, or breastbone. It gives us some really critical, easily palpable landmarks. Let's focus on the xiphoid process first, so the smallest, most variable bit at the bottom.
Right, the xiphoid. It's typically level with the T10 vertebra. Now, it's cartilage through childhood and adolescence, but a really vital clinical point is that it starts to turn into bone, usually after the age of 40.
Why is that specific timing, that ossification after 40, so important in a clinical setting?
Well, because the shape it ossifies into can be incredibly variable. It might end up as a sharp point or a blunt lump, or even be split, bifid, or curved.
Okay.
So imagine a patient hitting their early 40s. The structure suddenly hardens. They might feel this new, firm, kind of immovable mass right in the pit of their stomach, the epigastric fossa.
And they'd understandably worry it's something serious, like a tumor.
Exactly. They might fear they've developed an abdominal tumor. So the clinician's job is to recognize this, oh, this is likely your newly ossified xiphoid, and distinguish it from something truly pathological. It saves a lot of unnecessary anxiety and, frankly, costly investigations.
That must be a huge relief for the patient. Okay, shifting to trauma. The sternum is pretty well protected, right? By fascia, the pec major muscle.
Mm.
Fractures aren't that common unless it's a major crush injury.
That's right. Like hitting a steering column in a car crash, that's the classic mechanism.
Yeah.
And when a sternal fracture does happen, displacement is surprisingly rare because of all those surrounding attachments holding things together. However, the vulnerability definitely changes significantly with age.
Where's the weak spot, the most susceptible fracture site, particularly in older adults?
It's the sternal angle. That's the most common fracture site in older patients.
Why they're specific?
It's often because the manubriosternal joint, that fibrous joint between the manubrium, the top part, and the sternal body, it tends to fuse, to ossify in the elderly.
Ah, so it becomes one solid piece.
Right, it gets brittle and inflexible. So when trauma occurs, the break often happens right along that now fused line. It's essentially a dislocation of that previously mobile joint.
Okay, now, a completely different clinical angle.
Yeah.
The sternal biopsy. This is pretty common for harvesting bone marrow, isn't it? Why pick the sternal body over other bones?
Yeah, it's favored for two main anatomical reasons. First, its position, it's right under the skin, subcutaneous. That makes it really easily accessible without a lot of digging.
Easy access.
And second, its breadth. It's a wide target. A needle can easily pierce the relatively thin outer cortical bone to get into the abundant, highly vascular, spongy bone marrow inside. It's crucial for diagnosing various conditions. Think metastatic cancer or blood dyscrasias.
Blood dyscrasias, that's a clinical term for blood cell diseases.
Exactly, like leukemias or severe anemias where you need to examine the marrow directly.
Got it. And finally, what about congenital issues? What happens if the sternum doesn't fuse properly during development?
Incomplete fusion can lead to a couple of main issues. The most severe is a complete sternal cleft, where the two halves just never meet in the middle. This is often linked to a really catastrophic condition called ectopia cordis.
Ectopia cordis.
Yeah.
That's where the heart is outside the chest.
Yes, protruding entirely outside the protective thoracic cage. It's devastating. Less severe, but still important diagnostically, is something called a sternal foramen. This is just a small hole, a perforation, due to incomplete fusion.
And why is that important?
Clinicians need to recognize it on, say, a chest x-ray, so they don't mistake it for something else, like a bullet wound or some other pathology. It's just an anatomical variation.
Okay, let's turn to some mechanical problems of the chest wall, starting with a really severe, painful, and dangerous injury. Flail chest. What's the structural damage that causes this? And maybe more importantly, how does it physically mess up a patient's breathing?
Right, flail chest. It results from multiple rib fractures. The key is usually multiple fractures on the same ribs or fractures of several adjacent ribs, often in two places. This allows a whole segment of the chest wall to become detached, essentially, from the rest of the bony framework.
So it's just loose.
Exactly.
Yeah.
And the hallmark sign, as you hinted, is paradoxical movement.
Okay, walk us through the mechanics of that. Paradoxical movement, what does that mean?
Okay, so normally when you inhale, your chest expands, right? Creates negative pressure inside to draw air in.
Mm-hmm.
With flail chest, when the patient tries to inhale, that loose detached segment gets sucked inward by that negative pressure. It moves opposite to the rest of the chest wall.
So it collapses inward when it should be moving outward.
Precisely. And this obstructs the normal expansion, preventing the lung area underneath from inflating properly. Then, when the patient exhales and pressure increases, the loose segment bulges outward.
So completely backward.
Completely backward. And this severely messes up the normal pressure gradient you need for effective air exchange. It can lead really quickly to hypoxia, respiratory failure, often needs internal fixation, surgery to stabilize that segment and get the mechanics back to normal.
Wow. Okay. A powerful example of why that bony cage integrity is so vital. Let's talk about something maybe less dramatic but still significant. Supernumerary ribs. Extra ribs. Are they just curiosities or can they cause problems?
Well, it depends where they are. They aren't always benign if they arise in the wrong spot. The most significant type is the cervical rib.
Cervical meaning in the neck.
Exactly, arising from the seventh cervical vertebra, C7. It occurs in maybe 0.5% to 2% of people, so not incredibly rare. Although it might be small, this extra rib can be problematic because it narrows the superior thoracic aperture.
The exit doorway at the top of the chest.
Right. That's the route for all the neurovascular structures going to the upper limb. So if the cervical rib compresses the subclavian artery, or maybe more commonly the lower trunk of the brachial plexus,
That's going to cause arm symptoms.
big time. It can cause debilitating symptoms associated with thoracic outlet syndrome, numbness, tingling, pain, maybe impaired circulation in the arm or hand. Often requires surgical resection of that extra rib.
Okay, before we move down to the abdomen, let's clarify two terms that sound similar but mean different things in trauma. Rib separation versus rib dislocation.
Yeah, this distinction is actually quite important for accurate documentation and understanding the injury. Rib separation, strictly speaking, involves tearing the junction between the rib bone itself and its costal cartilage.
It's a costochondral junction.
Exactly. This usually happens with ribs 3 through 10, and it often allows the broken rib end to sort of override or slip over the rib above it. Very painful.
Okay, so separation is at the cartilage junction. What's dislocation then?
Rib dislocation, conversely, usually refers to displacement at one of the true joints, either the sternocostal joint, where the cartilage meets the sternum, or, less commonly, the costovertebral joint, way back where the rib meets the vertebra. So they're distinct injuries affecting different connection points, though honestly both are exceedingly painful.
All right, transitioning inferiorly now. We're moving from that bony fortress of the thorax down to the much more dynamic abdominal wall, a region defined largely by muscle, fascia, and that complex peritoneal membrane.
A very different landscape structurally.
Absolutely. Let's start with mapping it out, anatomical mapping and surface landmarks.
Yeah, you really can't examine a patient without having a mental map of the abdomen. It dictates where you listen, where you palpate, where you expect pain or organs to be. Clinically, we mainly use two systems.
Let's start with the more detail on the 9-region system. What defines those boundaries? How do we draw the lines?
Okay, the 9-region system gives you more precise localization. It uses 4 imaginary planes. You have 2 vertical sagittal planes, usually the midclavicular lines, dropping straight down from the middle of the collarbones.
Okay, 2 vertical lines.
And then 2 horizontal transverse planes. The upper one is called the transpyloric plane. It often crosses around the L1 vertebra level, sort of halfway between the jugular notch and the pubic symphysis.
Transpyloric, okay.
And the lower horizontal one is the transtubercular plane, which connects the tubercles you can feel on your iliac crests, typically around L5.
Got it. So those 4 lines create 9 boxes.
Exactly, like a tic-tac-toe grid.
Mm.
This system lets you be really specific when charting findings, saying a mass is in the epigastric region versus the right hypochondriac region, for instance.
And the other system, the 4 quadrants, that seems more common for quick assessments.
It is much faster for initial assessment, like in an emergency setting. It's defined simply by the median plane running vertically down the midline, and the transverse transumbilical plane running horizontally right through the belly button.
Okay, simple crosshairs.
Simple crosshairs. The key clinical insight here is knowing the level of that horizontal plane. It typically passes through the umbilicus, which corresponds to the L3, L4 intervertebral disc level. And obviously, knowing which quadrant usually holds the appendix, that's the right lower quadrant RLQ, or the gallbladder, right upper quadrant RUQ, is absolutely essential for a quick physical exam and focusing your diagnosis.
Definitely. Okay, let's talk about the nerve supply to the abdominal wall itself. We mentioned the subcostal nerve, T12, coming down from the thorax. What are the other key segmental nerves running in the wall, and where does that important T10 dermatome land?
Right, so the anterior abdominal wall gets its nerve supply primarily from the lower segmental nerves. Collectively, we call T7 through T11 the thoracoabdominal nerve.
Thoracoabdominal.
And then you add T12, the subcostal nerve we already mentioned. And L1 contributes via the iliohypogastric and ilioinguinal nerves, but focusing on T7, T12 for the main part. Now, T10 is a crucial landmark.
The belly button level.
Exactly. The T10 dermatome consistently supplies the skin right around the umbilicus. This is super helpful, for example, in neurology for localizing the level of a spinal cord injury, or even tracking the spread of a rash like shingles, which follows dermatomes.
Now, where do these nerves actually run within the layers of the abdominal wall? And why does a surgeon need to be so careful about them?
They travel in what's called the neurovascular plane. This is a specific layer, a space found between the internal oblique muscle and the transversus abdominis muscle, the deepest flat muscle.
Between internal oblique and transversus abdominis.
And they run in an infero-anterior direction, sort of downwards and forwards, along with the arteries and veins. Surgeons must meticulously preserve this plane during incisions.
Why? What happens if they're cut?
If you cut these segmental nerves, the portion of the abdominal wall muscles they supply will be denervated. This leads to muscle weakness, eventually atrophy, and potentially bulging or laxity of the abdominal wall over time. You can get a localized weakness or even a hernia later on. Even just placing a surgical drain has to be done carefully to avoid pressing on or irritating a nerve in this plane. Speaking of surgery, those layers of the abdominal wall are pretty formidable. Getting access requires balancing good visualization for the surgeon with preserving the function of the wall for the patient. So surgeons have developed different incision strategies.
Can you lay out the rationale behind some common ones, like comparing the midline incision versus that gridiron approach often used for appendectomies?
Sure, the median or midline incision is often the quickest way in. You cut through skin, superficial fascia, and go straight down the linea alba.
Linea alba, that fibrous seam right down the middle.
Exactly. The major advantage is speed, and it avoids cutting muscle or major nerves entirely, leaving great access to the whole cavity. The downside, though, is that the linea alba itself doesn't have a great blood supply. It's mostly fibrous tissue.
So healing might be slower.
It can compromise long-term healing, yeah, and potentially increases the risk of an incisional hernia developing later on where the scar tissue weakens.
Okay. Now what about that oblique muscle-splitting incision, the gridiron or McBurney incision, often used for the appendix?
Right, the gridiron or McBurney incision. It's oblique, down in the right lower quadrant usually. And the key here is that it's designed to split the muscle fibers along the direction they naturally run rather than cutting across them.
So you separate them instead of transecting them.
Precisely. You split the external oblique, then the internal oblique, then the transversus abdominis, following their fiber directions. This minimizes muscle damage and, crucially, preserves the nerve supply traveling between those layers, especially the iliohypogastric nerve, which is nearby.
So better healing and function long term.
Generally, yes. McBurney's insight was that splitting muscle fibers heals better and leads to a stronger, more cosmetic result for the patient, even if the surgical access might be a bit more limited than a big midline cut.
You also mentioned some incisions are considered high risk now.
Yes, the pararectus incisions. These run vertically just alongside the border of the rectus sheath, the sheath enclosing the six-pack muscle.
Seems logical for access to things on the side.
It seems logical, but they're high risk because they run precisely where those segmental thoracoabdominal nerves pierce the sheath to supply the rectus abdominis muscle.
So you're likely to cut the nerve supply to the rectus.
Very likely. And that leads to the consequences we just discussed: denervation, muscle atrophy, and abdominal wall weakness on that side. So they're largely avoided now, if possible.
Okay. Let's talk about abdominal swelling or protrusion. There's that classic mnemonic, the 6 Fs. How does knowing those categories help in a quick assessment or triage?
The 6 Fs: food, fluid, meaning ascites, pathological fluid; fat, feces, constipation, obstruction; flatus, gas; and fetus, pregnancy. They provide a really rapid clinical checklist.
Just runs through the common causes.
Exactly. Instead of jumping immediately to rare tumors, a clinician first thinks, is this likely chronic, like fat or a fetus developing, or more acute, like sudden fluid buildup, severe constipation, or gas? It helps direct the immediate investigation pathway. And a simple visual cue that often signals something pathological, like significantly increased intra-abdominal pressure, maybe from massive ascites or a large tumor, is the everosion of the umbilicus, the belly button popping outward.
Right, that makes sense. Okay, focusing on hernias for a moment, specifically umbilical hernias around the belly button.
Yeah, umbilical hernias are extremely common in neonates, especially premature babies or those with low birth weight. It's basically due to incomplete closure of that umbilical ring where the cord was.
Do they usually fix themselves?
The good news is, yes, most small defects close spontaneously within the first few years of life. But you can also get acquired umbilical hernias later in life. These often develop in obese individuals or women after pregnancy, basically due to chronically high intra-abdominal pressure pushing things out through that naturally weaker spot. Usually it's extraperitoneal fat or peritoneum that protrudes.
Oh, let's delve into the peritoneum itself, this complex, huge, serous membrane. It doesn't just line the cavity, it defines critical spaces and pathways for fluid and, unfortunately, infection. Let's start by defining the two major sacs, or compartments.
The main space, the one you enter during most abdominal surgeries, is the greater sac. That's the main peritoneal cavity.
Okay, the big one.
Then tucked away posterior to the stomach, and the lesser omentum, that's the membrane connecting the stomach to the liver, there's a smaller, more hidden space called the omental bursa, or the lesser sac.
Lesser sac, behind the stomach. And how do these two connect? Is there a doorway?
There is a single connection point, a natural opening called the omental foramen, which used to be called the foramen of Winslow. That's the only way fluid or structures can normally pass between the greater sac and the lesser sac.
Given its huge surface area and the fact that it's semi-permeable, clinicians have found a really clever, non-surgical use for the peritoneal dialysis.
It's a fantastic application of anatomy and physiology because the peritoneum is lined by this immense network of capillaries and acts like a filter, a semi-permeable membrane. We can use it as a substitute kidney, essentially, in patients with renal failure.
How does that work?
A sterile, specialized fluid called dialysate is introduced into the peritoneal cavity via a catheter. Waste products like urea and creatinine, which are in high concentration in the patient's blood, naturally diffuse across that peritoneal membrane from the blood into the dialysate fluid.
Following the concentration gradient.
Exactly. Then, after a set time, that fluid, now containing the waste products, is drained out and replaced with fresh fluid. It uses the body's own membrane to clean the blood.
Clever. Now, let's talk about a structure within the peritoneum, the policeman of the abdomen, the greater omentum. Why does it get that nickname?
It's very well earned. The greater omentum is this large, apron-like fold of peritoneum that hangs down from the stomach and covers the intestines. It's highly mobile, and it contains a lot of fat and immune cells.
So what does it do?
When there's localized inflammation or infection somewhere, let's say, an acutely inflamed appendix or maybe a perforated ulcer leaking stomach contents, the omentum actively migrates to that spot. It literally moves towards the trouble.
Really? It moves?
Yeah, it adheres to the inflamed site, wrapping around it and forming protective adhesions. It tries to wall off the infection, contain the spill, and prevent it from spreading throughout the entire peritoneal cavity, causing generalized peritonitis. It's a critical natural defense mechanism.
Like sending in the police to contain a situation.
Exactly like that.
Speaking of infection spreading, what anatomical structures act as the main highways for fluids, whether it's ascites, blood, or infected pus within the abdomen?
Those would be the pericolic gutters. These are channels, essentially grooves, located vertically on either side of the ascending colon on the right and the descending colon on the left.
Gutters alongside the colon.
Right. They act as natural pathways. Fluid tends to flow along these gutters following gravity. Understanding these pathways is crucial for surgeons trying to figure out where bleeding might be coming from or how an infection might have spread from, say, the appendix upwards towards the liver.
And this understanding of fluid flow and gravity leads to a specific patient positioning technique, right? Why are patients with widespread peritonitis often placed sitting slightly upright in that semi-Fowler's position?
Yeah, that's a therapeutic strategy that uses gravity and anatomy to our advantage. By elevating the patient's torso maybe to 45 degrees or so, any infected fluid or exudate is encouraged to flow downwards into the lowest points of the peritoneal cavity.
Which are in the pelvis.
Exactly. In males, that's the rectovesical pouch between the rectum and bladder. In females, it's the rectuterine pouch, also known as the pouch of Douglas, between the rectum and uterus.
And why is it better for the fluid to collect there?
Two main reasons. First, absorption of toxins is generally thought to be slower from the pelvic peritoneum compared to the diaphragmatic peritoneum higher up. Second, and maybe more critically, these dependent pouches are the easiest places for a surgeon to access surgically or to place drains to remove the infected material. It helps contain the infection and facilitate drainage.
Makes sense, drain it from the lowest point. Lastly, on the peritoneum, a dangerous but rare situation. Internal hernias involving that omental foramen, the doorway to the lesser sac.
Yeah, this is extremely dangerous. It's uncommon, but a loop of small intestine can sometimes slip through the omental foramen into the lesser sac.
And get stuck.
Yeah. Strangled by the rigid, unyielding boundaries of the foramen. The really crucial anatomical point here is what forms the anterior border of that foramen. It's the portal triad.
Hepatic artery, portal vein, and bile duct. Reader structures.
Absolutely vital structures running in the edge of the lesser omentum. So you cannot just cut the edges of the foramen to release the trapped bowel because you'd risk catastrophic bleeding or bile leakage.
How do you fix it?
It's very tricky. Often, it requires delicate needle decompression of the swollen, trapped loop of intestine while it's still in the lesser sac to reduce its size, before it can be very gently manipulated and guided back through the foramen into the greater sac. It's often a race against time because the blood supply gets cut off quickly, leading to ischemic necrosis, gangrene of the bowel.
Okay, let's descend now into the pelvis, the basin that supports and protects all those vital, visceral, urinary, and reproductive structures down there.
The foundation at the bottom of the trunk.
Exactly.
Yeah.
Let's start with the bony pelvis itself and its joints.
Right, the pelvic girdle. It's really a masterpiece of engineering. It has this remarkable dual function. It has to bear and transfer the entire weight of the upper body down to the lower limbs when you're standing or sitting. And at the same time, it has to protect and provide a solid foundation for all the abdominopelvic viscera contained within it.
Let's focus on the big power joint back there, the sacroiliac joint, the SI joint. How does this joint manage such immense weight transfer while staying incredibly stable? Doesn't seem like it moves much.
It achieves its stability through a really clever combination of strong ligaments and interlocking joint surfaces. When your axial weight, the weight from your spine, presses down on the sacrum, it naturally tries to drive the top of the sacrum downwards and forwards relative to the iliac bones. This tilting movement is called nutation. But this movement is powerfully resisted, primarily by the extraordinarily strong interosseous sacroiliac ligaments. These ligaments are deep between the bones and act almost like a suspension system or a pivot point.
So the ligaments aren't just passively holding bones together, they're actively involved in the mechanics.
Precisely. They facilitate what's called a force closure mechanism. As the sacrum tries to tilt forward under load, these ligaments get taut and actually pull the iliac bones medially, squeezing them inward against the wedge-shaped sacrum.
So the pressure locks the joint tighter.
Exactly. It compresses and locks the irregular but congruent surfaces of the joint together, almost like a key fitting perfectly into a lock. It's this sophisticated ligamentous bracing combined with the shape of the bones that gives the SI joint its incredible stability under load. Without it, the joint would just shear apart.
Fascinating. Okay, moving around to the front, how is the pubic symphysis structured? The joint connecting the two pubic bones.
The pubic symphysis is a different type of joint. It's a secondary cartilaginous joint. The two pubic bones are united by a thick pad of fibrocartilage called the intrapubic disc.
Fibrocartilage, so it allows a little bit of movement.
A very small amount, yes. And this joint is generally wider and allows slightly more movement in women, especially during late pregnancy when hormones like relaxin cause the ligaments to soften, allowing the pelvis to expand slightly for childbirth.
And what reinforces this joint?
Its strength mainly comes from two strong ligamentous bands, the superior pubic ligament running across the top, and the very thick and strong inferior pubic ligament, also called the arcuate pubic ligament, which forms the strong base beneath the joint, blending into the pubic arch.
Okay, below that bony rim lies the real functional support system, the dynamic, almost funnel-shaped pelvic diaphragm. What are its main muscular parts?
It's primarily composed of two muscles, or muscle groups, really. Posteriorly, you have the smaller coccygeus muscles. But the main player, the dominant muscle mass forming most of the floor, is the levator ani muscle group anteriorly.
Levator ani, the lifter of the anus.
Exactly. It acts like a muscular hammock or sling, stretching between the pubic bones anteriorly and the coccyx and sacrum posteriorly. It's the primary dynamic floor.
Within that levator ani complex, there's one part we really need to focus on, the puborectalis muscle. Why is this U-shaped sling so important anatomically and clinically?
The puborectalis. It's absolutely crucial, mainly for continence. Its fibers originate from the pubic bones and form a U-shaped sling that loops around the back of the anal canal, specifically at the anorectal junction.
Okay, a sling around the back passage.
Right. And in its resting state, this muscle maintains a constant tonic contraction. It's always slightly active. This constant pull draws the anal canal forward, creating a sharp angle, the anorectal angle.
A kink in the tube, basically.
Pretty much, yeah, a kink. And this angle is paramount for maintaining fecal continence. It acts like a flap valve. For defecation to happen, this muscle has to constantly and completely relax. That relaxation straightens out the angle, allowing stool to pass.
So that muscle is damaged.
If that muscle is damaged or its nerve supply is compromised, fecal continence is immediately jeopardized. It's that critical.
Which leads us right into the clinical implications of pelvic floor injury, most commonly linked with childbirth, right?
Yes, childbirth, especially if it's a prolonged labor, a difficult delivery needing forceps, or involves large babies, subjects the pelvic floor muscles to extreme stretching and potentially tearing. Injury to the levator amani, particularly those pubococcygeus and puborectalis portions that form the sling.
Yeah.
It leads to a significant loss of that vital visceral support. Clinically, this can manifest in several ways. Immediately, or soon after, you might see urinary stress incontinence, leaking urine with coughing, sneezing, jumping.
Because the bladder neck isn't supported properly.
Exactly. But the long-term issues can be even more profound. Things like pelvic organ prolapse, where the uterus, bladder, or even the rectum can descend or bulge down into the vagina because the hammock underneath is weakened.
And that can cause other problems, too.
Oh, yeah. Chronic weakness, maybe from nerve damage during delivery, can also lead to difficulty emptying the bladder fully. The patient strains to void against this weakened, unsupported floor. This can cause the bladder muscle itself to hypertrophy, get thicker, but eventually it might fail, leading to residual urine being left behind after voiding.
And residual urine increases infection risk.
Dramatically increases the risk of recurrent urinary tract infections, UTIs, and even bladder stone formation. So the initial muscle injury has long-lasting consequences.
Okay, let's clarify the supportive tissues here, the pelvic fascia.
Yeah.
It sounds like there are different layers. How do we differentiate parietal versus visceral fascia?
Right. Fascia is everywhere, providing support. In the pelvis, we distinguish between the parietal pelvic fascia, which is the layer that lines the internal surfaces of the muscles forming the pelvic walls, muscles like obturator internus laterally, and the levator ani forming the floor. Think of it like wallpaper on the muscular walls.
Okay, lining the muscle.
Then you have the visceral pelvic fascia, which is the layer that directly ensheaths the pelvic organs themselves. The bladder, the uterus, the rectum. It's like the wrapping around each organ.
And where these meet is important.
Well, where the parietal fascia thickens along the pelvic floor, particularly over the obturator internus muscle, it forms a crucial landmark called the tendinous arch of pelvic fascia. This arch serves as an important attachment point for parts of the levator ania and also for supports holding up the vagina.
What's the clinical relevance of really understanding this fascial separation, especially for surgeons working in the pelvis?
Oh, it's absolutely critical, particularly in radical pelvic surgeries like removing the prostate, prostatectomy, or the uterus hysterectomy. Surgeons rely on finding and staying within the correct plane between the visceral fascia covering the organ they're removing and the parietal fascia lining the pelvic wall.
Why is that plane so important?
Because the delicate autonomic nerves, including the cavernous nerves essential for erectile function in males, run within or just deep to these fascial layers, particularly along the pelvic sidewall. If the surgeon doesn't carefully dissect within the correct plane, respecting these fascial layers, they can easily damage these nerves.
Leading to significant post-op complications.
Exactly. Devastating complications like urinary incontinence or erectile dysfunction. Knowing the fascia helps preserve nerve function.
You mentioned a specific supportive structure in females. The pericolpia, what are those?
Yes. The pericolpia are specific thickenings or condensations of that visceral pelvic fascia that run laterally, suspending the sides of the vagina. They essentially anchor the upper vagina to that tendinous arch of pelvic fascia on the pelvic sidewall.
So they hold the vagina up.
They're essential support structures, yeah. They help the vagina bear the weight of the organs above it, particularly the base of the bladder. And they become really important surgically. They are key targets during procedures to repair vaginal prolapse, trying to resuspend the vagina from these strong fascial points. Okay, let's shift focus slightly to neurovasculature and visceral pain in the pelvis. Thinking about the ureters first, those muscular tubes carrying urine from the kidneys down to the bladder. Kidney stones, or calculi, can cause incredible pain when they get stuck. Where are the three predictable anatomical narrowings or constrictions where a stone is most likely to get lodged?
Right, knowing these points must be essential for looking at x-rays or CT scans to find the stone.
Absolutely. The three classic sites are, number one, the ureter-pelvic junction, or UPJ, right where the funnel-shaped renal pelvis narrows down to become the ureter proper as it leaves the kidney.
Okay, leaving the kidney.
Number two, where the ureter crosses over the major blood vessels, specifically the external or common iliac artery, as it dips over the pelvic brim to enter the true pelvis.
Crossing the iliacs.
And number three, where the ureter traverses through the muscular wall of the urinary bladder itself, there's a sort of oblique tunnel it takes, and that's another narrow point.
And the pain comes from the ureter trying to squeeze the stone through these narrowings.
Exactly. These constrictions require the smooth muscle in the ureter wall to contract really forcefully hyperperistalsis proximal to the obstruction, trying to push the stone along. That intense, cramping contraction is what causes the characteristic pain known as ureteric colic.
Can you describe that classic referred pain pattern? Where does the patient feel it?
Ureteric colic is typically severe. Fluctuating pain comes in waves. And the pain is referred along the dermatome supplied by the same spinal cord segments that receive sensory information from the ureter, which are mainly T11 down to L2.
T11 to L2.
Right. So classically, as the stone moves down the ureter, the pain is described as migrating intensely from the loin to the groin. It often starts high up in the flank or lumbar region, the loin, then follows the course of the ureter downwards and forwards towards the inguinal region, the groin, and it can often radiate further down into the external genitalia, the labia majora in females, or the scrotum in males, because those areas share some of the same innervation pathways, like the genitofemoral nerve, L1, L2.
Loin to groin, a classic pattern. Okay, shifting focus to the male pelvis now. Benign hypertrophy of the prostate, BHP, a condition that's almost universal in older men. What specific part of the prostate enlarges typically, and how does that cause the urinary symptoms?
Right. BHP involves the non-cancerous enlargement of the prostate gland. While different parts can enlarge, the issue that most commonly causes urinary obstruction stems from the enlargement of the middle lobule or median lobe of the prostate.
The middle lobule, and where does that sit?
This lobule sits just posterior to the upper part of the prostatic urethra, right below the bladder neck. As it enlarges, it projects inward, up into the bladder outlet, and directly impinges upon or distorts the prostatic urethra as it passes through the gland.
So it basically squeezes the urethra shut.
It obstructs the flow, yeah. It prevents complete emptying of the bladder.
What are the primary symptoms that brings men in? And what are the downstream effects if this chronic obstruction isn't treated?
The symptoms are pretty classic. Nocturia, having to wake up multiple times at night to urinate. Dysuria, which can mean difficulty starting the stream, a weak stream, hesitancy or dribbling at the end, and urgency, feeling like you have to go right now.
Okay, nocturia, dysuria, urgency.
Those are the main ones. Now, if it's left untreated, the bladder muscle, the detrusor muscle, has to work much harder to push urine out against this obstruction. Initially, the bladder wall might get thicker hypertrophy to compensate.
Like any muscle working against resistance.
Exactly. But eventually, this compensatory mechanism can fail. The bladder might become distended, lose its tone, and crucially fail to empty completely. This leaves residual urine behind after voiding.
And we mentioned residual urine is bad.
Very bad. It dramatically increases the risk of recurrent UTIs because bacteria can thrive in that stagnant pool. It also increases the risk of bladder stone formation. So the initial anatomical enlargement drives a whole cascade of clinical problems. Okay, our final anatomical stop is the anal canal. And here, there's one really critical landmark, the pectinate line, that divides the canal into two drastically different zones, both anatomically and clinically. This difference is perfectly illustrated by how hemorrhoids present.
The pectinate line, that marks the embryological transition point,
Yeah.
right? And it dictates differences in blood supply, nerve supply, lymphatic drainage, everything.
Absolutely. It separates the upper part, derived from hindgut endoderm, from the lower part, derived from surface ectoderm. So above the line, you have visceral innervation and drainage, mainly to the portal venous system. Below the line, you have somatic innervation and drainage to the caval systemic venous system.
Okay, let's start with the hemorrhoids that occur above the line, the ones that are typically not painful.
Right. Those are internal hemorrhoids, sometimes just called piles. They occur superior to the pectinate line. What they actually are is prolapses of the rectal mucosa that contain dilated veins from the internal rectal venous plexus.
Internal plexus drains to the portal system.
Correct. And because this area above the pectinate line is supplied by visceral afferent nerves, these hemorrhoids are generally insensitive to pain, touch, or temperature. They often present with bright red bleeding during or after defecation, but they usually only cause discomfort if they prolapse far enough out of the anal canal and maybe become constricted or thrombosed secondarily.
Okay, insensitive to pain. Now, conversely, the ones below the pectinate line.
Those are external hemorrhoids. They occur inferior to the pectinate line. These are typically thrombosis, blood clots forming within the external rectal venous plexus, which lies under the skin around the anal orifice.
The external plexus drains to the caval system.
Right. And crucially, since this region below the pectinate line is supplied by somatic sensory nerves, specifically the inferior rectal nerves, which carry pain and touch sensation.
These ones hurt.
These ones hurt. External hemorrhoids are typically very tender, itchy, and can be acutely painful, especially when thrombosed. Patients know they have them because they can feel a painful lump. So the pectinate line makes all the difference in symptom.
A really clear clinical distinction based on that anatomical line. Okay, to wrap up our clinical synthesis, let's compare the three main regional nerve blockades used in obstetrics to manage the pain of labor and delivery.
Yeah, understanding the anatomical target and effect of each is key for managing labor pain. First, probably the most common, is the epidural block.
Epidural. Where does the needle go?
The anesthetic solution is injected into the epidural space, that's the potential space outside the dura mater, containing fat and blood vessels, usually at the L3, L4 vertebral level in the lower back.
Okay, into the epidural space, what does it numb?
The anesthetic bathes the spinal nerve roots as they exit the dura. This effectively anesthetizes the lower birth canal, cervix, vagina, perineum, and the pelvic floor muscles. Critically, though, the pain fibers coming from the contracting uterine body travel up to higher spinal levels, thoracic and upper lumbar.
So the mother can still feel the contractions.
Generally, yes. She often retains the sensation or awareness of the uterine contractions, which is important because it allows her to push effectively during the second stage of labor. And because the dura isn't punctured, the risk of a post-procedure spinal headache is very low.
Okay, good pain relief for the pushing part, but still feel contractions. Now the spinal block, that sounds more intense.
It is. A spinal block involves injecting the anesthetic deeper, directly into the subarachnoid space, the space containing cerebrospinal fluid, CSF, again, usually at the L3, L4 level.
Into the CSF itself.
Right. This produces a much more rapid, dense, and complete block, both motor and sensory anesthesia below the waist. It usually temporarily blocks lower limb function, and it completely blocks the sensation of uterine contractions.
So complete numbness below the waist.
Pretty much, yeah. Because of this rapid, profound block, it's often reserved for procedures where you need quick and complete anesthesia, like a plan or emergency cesarean section. The main downside is the risk of a severe spinal headache if CSF leaks out through the dural puncture site and it doesn't seal quickly.
Okay. And finally, the most localized option, the pudendal block.
The pudendal nerve block is quite different. It's a peripheral nerve block, not a spinal or epidural. The anesthetic is injected near the ischial spine, aiming to numb the pudendal nerve, which comes from spinal roots S2, S3, S4.
Targeting just a pudendal nerve.
Exactly. This nerve primarily supplies the perineum, the skin and muscles between the vagina and anus and the lower part of the vagina. So a pudendal block specifically anesthetizes that region.
So just the exit area.
Primarily, yes. It provides targeted pain relief mainly for the very end of labor, the delivery itself, and for performing or repairing an episiotomy or perineal tears. The mother retains full awareness of her uterine contractions and has full motor control above the pelvis. It's often used for quick, low-complication deliveries or when an epidural isn't available or desired.
Wow. We have definitely completed an exhaustive deep dive today. We established the bony protection and the clinical weak points of the thoracic cage, navigated through the functional subdivisions and those important flow pathways of the abdomen and peritoneum, and then analyzed the dynamic and often vulnerable support systems of the pelvic floor.
The depth of the interconnections across these regions is really quite staggering when you lay it all out. From the specific way kidney stone pain refers along dermatomes, reflecting shared nerve pathways, to the absolute necessity of preserving that neurovascular plane between muscle layers during abdominal surgery, or that stark difference in pain sensitivity created by the pectinate line in the anal canal. These anatomical rules really do underpin all safe and accurate clinical practice.
It really has been a powerful illustration of the body's intricate design. If you had to pick one overarching theme that ties together these diverse cavities and their structures, what would it be?
That's a great question. I think the theme that keeps emerging is redundancy. The body's built-in backup plans, we saw it everywhere, didn't we?
How so?
Well, think about the robust ligamentous locking mechanism of the SI joint, multiple structures contributing to stability. Think about the multi-layered sphincter systems, both urinary and anal, providing layers of control. The incredible mobility and function of the greater omentum acting almost like a natural surgical assistant to wall off infection. And the extensive network of anastomoses, collateral connections between blood vessels that protect vital structures like the ureters and the abdominal viscera if one pathway gets compromised. The body is very rarely reliant on just a single pathway or a single structure for survival.
So this layered, redundant engineering.
It's often the very thing that buys a patient time and allows for successful intervention when trauma or severe pathology occurs. It's built to withstand challenges.
That's a wonderful thought. The human body isn't just designed to function, it's often designed to fail safely, or at least with some backups in place.
Indeed. Well put.
Next time, we will complete our study of the abdomen by examining the diaphragm and the muscles, nerves, and vessels of the posterior abdominal wall. We'll dive into structures like the lumbar plexus and the major great vessels, the aorta and vena cava back there.
Looking forward to it.
Thanks for joining us for this deep dive.